Okay, so Twila Brase, President and co-founder of Citizens Council for Health Freedom, CCHF, champions patient and doctor freedom through her role in this national nonprofit organization established in 1998. She is the author of Big Brother in the Exam Room, The Dangerous Truth About Electronic Health Records. Twila has successfully advocated for parental consent in newborn DNA research, exposed HIPAA's data sharing implications, and founded the Wedge of Health Freedom, an online directory for direct pay practices. Twila launched the Patient Toolbox, a tool to help patients maintain control over treatment decisions. During the COVID crisis, she initiated CCHF's Face Freedom campaign and a Don't Be Bullied billboard campaign. Twila's efforts also led to President Trump's 2019 executive order to allow Americans to opt out of Medicare without losing Social Security benefits. Her Health Freedom Minute reaches more than 5 million listeners daily on 870 radio stations nationwide. Twila engages with healthcare policymakers, conducts original research, speaks nationwide, and has gained media recognition from outlets like CNN, Forbes, Fox News, and the Wall Street Journal. In 2021, she authored CCHF's COVID-19 Quick Reference Guide, downloaded more than 140,000 times. Recognized in Modern Healthcare's 100 Most Powerful People in Healthcare and in Minnesota Physicians' 100 Most Influential Healthcare Leaders, Twila testified before the Wyoming legislature in 2022. Her efforts in Montana led to the passage of the nation's strongest genetic privacy law in 2023. Please give a warm welcome to Ms. Twila.
Do I know it's on?
You talking to it?
Is it on?
Yeah.
Okay, good. She said hold it down 3 seconds and then go. I'm like, nothing changed. Well, it's always good to be here. Thank you so much, Jan, for inviting me. I am just beginning a tour that's going all the way down to Florida and back and doing a whole bunch of presentations and meetings on the way. So it's always nice to stop here as a first stop, which I've done several times, and to see your faces again, and just to have an opportunity to talk about how things have maybe changed, for example. And so first of all, can you hear me well enough? Okay. Some people cannot hear me well enough. Okay. What I really don't want to do is to have pops. So if I have to have it louder and more pops come, just if you'd be willing to turn it down a little if that happens, because I know that can be irritating. Okay, so my presentation today, I want to talk about health plans, which people think of as the private market, and Medicare, which a lot of people don't understand, but are looking for help on. And then I'm actually not going to talk a lot about privacy, but perfectly happy to do so because it is what we are known for around the country as an organization. But and then there's a COVID update because I just think there's important things for you to know. So as an introduction to the organization for some of you who may not know, so this is a picture from I think January 30th maybe or 31st in front of the speaker's office. So Matt, my policy director, and I were there to talk to the speaker's office about trying to make sure that you would have the ability to opt out of Medicare without losing your Social Security benefits. This is what was talked about in my biography, the executive order that we got in 2019. But then, of course, COVID intervened. The rule was written. They didn't actually put it out because they waited to see if Trump would be reelected, and as you know, he wasn't. So anyway, I went to the Speaker's office to say, bring back that bill, the Retirement Freedom Act, which would do the very same thing that Trump's executive order would do. So that's just a very new photo there. So this is, we just finished our 25th anniversary last year. And we work nationwide, and we work in different states, and just, let's see what day is it?
13.
Yeah, I think it was last week that we were in New Hampshire testifying on a bill that would be the strongest privacy law in the nation if it would happen. But there were 10 people testifying in front of me, and the author had invited me and Matt to come from Minnesota. And then it was great to have been the last person to testify, because that means that I got to talk about how they were all wrong ahead of me. So they probably thought they were being clever, but I was thinking, this is great. Okay, we're independent, nonpartisan, patient-centered, privacy-focused, and free market. So I want to talk about the health plans, because I don't think people know enough about really what the health plan is. It's been called by Republicans, this is the private market, this is the free market at work, without people actually understanding how this thing came to be. So here is the history for you to take a look at. 1943 is when Congress decides that employers can offer health insurance as a tax-free benefit. So they get a deduction, right? This was the beginning of pulling everybody together into groups. And so pulling people away from having individual insurance that would pay them, pulling them away from having an insurance policy that met their needs, diverting their income at work into a plan today that they can't even pick. So today, you might think you have free health care, but you don't. They're just taking a part of your income and diverting it to the plan that they have chosen for you. And it's a huge diversion, because it's a huge amount of money, and then you can't necessarily even get the care that you want when you want it, and you can't take it with you. Okay, Medicare, that was started by John Dingell, a Democrat in Michigan. The HMO Act of 1973 was Ted Kennedy's plan to bring socialized medicine to the private market by making a corporate version of it called the HMO, and now called the health plan. So just understand that. The health plan that we have today, the corporate version of socialized medicine. So in 1993, Bill and Hillary decided to give us HMOs for all. They weren't successful, as you know. But then Medicare Advantage, which was a Republican initiative to put seniors into HMOs, now called health plans. This is called Medicare Advantage. And in this presentation, I'm going to describe Medicare Advantage as one of the Medicare traps. In 2003, that was Medicare Advantage by Hastert, and 2010, the Affordable Care Act, which gave us health plans for all, unless you're in a health sharing organization. And catastrophic coverage, real insurance, was prohibited, and still is today. And then 2023, 52% of all Medicare recipients are in health plans, Medicare Advantage. All right, just really want you to see that the health plan is not the private market. It's not freedom. It was put there by Democrats. And then, and by the way, when Kennedy did the HMO Act of 1973, he had Richard Nixon's blessing. And if you look online, you can see a quote, they actually in part of Nixon's tapes, you know, somebody talking to him and him saying, like, this is a great idea to do these HMOs. And really just the corporate version of medicine, of healthcare, is because very much like socialized medicine in Canada, England, or anywhere else you want to look at, they pay money out of their taxes, right? And then they hope that there will be care for them when it's all done, when they have something that they need. But there's no guarantee that there will be. It's prepaid health care, and officially in our laws, health plans are called prepaid health care. But officially also, the health plans are allowed to deny you access to care because of things that they think are not medically necessary, even though your doctor thinks they are very medically necessary. By law, they can deny you access to care. So the Medicare traps. Let's move to Medicare traps. So we're in the midst of writing a handbook for Medicare, because so many people don't understand the choices when you get there, and they don't understand the traps. So I'm just going to share some of the traps, but in order to understand it, it's good for you to know just where Medicare is at today. So Medicare's in trouble. Uh, 2022, there were 65 million recipients. And I don't call people beneficiaries. They're not beneficiaries. They're recipients. And you might think you're a beneficiary because you paid all of your life for Medicare. But in matter of fact, studies will show that you will get 3 times as much in care as you ever paid. And just look at your Social Security statement. See how much you paid for Social Security versus what you paid for Medicare. A lot of people will find that Medicare amount to be that they paid $50,000 over their lifetime. Is that going to cover all your medical expenses for the last 30 years of your lifetime? Because a lot of people are living into their 90s, some into their 100s, right? So this is why it's been called the Ponzi scheme, right? There's very little coming in. A lot of the people in the very beginning, when there were more workers contributing, they got a great deal. But this is going to be very difficult in the next 10, 20, 30 years. So in 2022, Medicare paid $53.9 billion more than they received in revenue. In 2023, that's 45% more that was spent than came back. There are 10,000 baby boomers entering every day, and part of the way that they want to deal with this is giving physicians a cut. So starting in January 1st, 2024, they cut physician payments 3.2%. Just giving physicians one more reason not to stay a physician or not to do Medicare. Okay, in 2031, how many years from now is that? 2031?
7.
In 7 years, asset depletion. There will not be enough money coming in from payroll taxes to pay all of the Medicare expenses, and they expect it to be able to pay only 89% of all the bills. And in 2033, in 2033, 80 million people will be dependent on Medicare, which will not be able to fully pay the bills. This is one reason why they want you into a health plan, because the health plans ration care. All right, so Medicare's in trouble, so here's a graph to show you what kind of trouble they're in. And just to be clear, this red here is the hospital Part A. And you see it's going to run out of money on 2031. And the bills will be paid as the payroll taxes come in. So it's not like there's going to be any trust fund, any savings, any anything, right? It'll be done. Now, this was actually supposed to be 2028. until the trustees report of last year, and they said, oh, 3 more years. Personally, I think the 3 more years are the result of so many older people dying from COVID and from all the different things that they refused to do during COVID, right? So these are some other things, like this is disability insurance, and I think this is Social Security itself, and this is Social Security disability. Okay, so you get an idea, because Social Security is in trouble too. 2034. All right, next. All right, and so this gives you an idea of how the money comes into Medicare. So you have a better idea when I say, you know, maybe you've only paid $50,000 over your entire year. Entire lifetime of working. This is what pays for Medicare. So these are the payroll taxes. You see what a small amount they are? Here's the tax on Social Security. Here's the premiums you pay for like Part B. And then here's the government contribution for Part B. And Part A. It's all the whole government. And up here you can see the deficit. And here is about 2031. That's about when it starts, right up there, where they won't have enough money to pay the bills. This all comes from the trustees, as well as some other news articles regarding what the trustees have put out. And so this has to do with the workers. So, you know, in 1965, Medicare got passed. In 1966, Harry Truman got the first Medicare card, like he needed it, right? But he was a huge proponent of national health care. So this is 1970 here. And you can see how the enrollment just advanced, but you can see over here from 1970 how the number of workers paying in for the payroll tax has decreased significantly. So we're coming at this like, you know, what do they call it? The perfect storm, right? Too few workers, 10,000 baby boomers entering Medicare every day, and the money just not being there. So here is this was the MedPAC, this is a quote from MedPAC about the Medicare trustees report. Funding will rise from 3.6% in 2015 to 5.7% by 2035. The rapid growth in the number of beneficiaries began in 2011 and will continue through 2030 as members of the baby boom generation reach age 65 and become eligible to enroll in Medicare. And then they're in there for a very long time as our ages, people are just living longer. All right, so let's just talk about the Medicare traps. So this gives you the background you need to know about Medicare, and we'll probably give you some understanding why they would like to have you in a health plan, because the health plan is able to take all the money from the federal government and then decide whether or not to actually give you what you need. All right, so Medicare trap number 1 is just the fact of Medicare. When you turn sick, there's no escape unless you choose, you're just so independently wealthy that you're not going to go into Medicare and you're going to pay all of your bills by cash. Now, I actually know somebody like that who's a physician who has argued his bills down, and because he's a physician, let me just give you an idea of what he does. He was given a bill of, I think, or a cost of like $108 or I think it was $108,000 for whatever he needed. And then he said, that's ridiculous. I'm a physician. I know that it doesn't cost anywhere near that. And she said, oh, you're a physician paying cash? Okay, the bill for you is $11,000. Oh. Mm-hmm. Yes. So, you know, the prices of things are interesting. All right, but everybody is forced into Medicare at age 65, and you are suddenly senior. And you know, for many places, they might actually look at you differently, and it's because you're Medicare age. Before Medicare, when you went from 64 to 65, nobody said, nobody thought. There's nothing to think about. But now it's like, now you're Medicare age. And now the government is paying for you. You're dependent on the federal government. I told about the looming insolvency. Medicare Advantage is the way to corral. It's a corral for patients and doctors. you may not understand it, but you will not get your Social Security benefits if you do not enroll in Medicare. And I do know some people who just don't, because they have better insurance, they want to use that insurance, they were grandfathered into that insurance, they're in their 80s or 70s, but they don't want to go through the hoops of Medicare, and they want to just get the care that they need. And so they have opted to lose, $40,000, $30,000, $20,000 a year to keep their insurance and get the care that they need. And then, there's no Social Security benefits if you refuse to enroll because of what the Clintons did in 1993. They tied them together, no law, no rule. They just made a decision. It's been followed ever since. The lawsuit was unsuccessful because of Kavanaugh's decision, and then the Supreme Court denied cert, and then we got the executive order, but then COVID intervened. So we're waiting for the next president to see what we can do. And then if you're still working, you have to pay more in Medicare. So you're forced into Medicare unless you have employment of 20 or more employees in your business. If you have less, you're forced into Medicare. And if you don't go into Medicare, there are any number of penalties for not going in. But then if you are still working and you are forced into Medicare, you pay a lot more money. Instead of $174, you might be paying $260 or $350 because you're working. All right, Medicare insolvency. All right, this is from the trustees' report last year. So the total Medicare expenditures are expected to exceed non-interest revenue for all future years. Transfer from the general fund of the Treasury will continue to outpace GDP growth, and HI, that's the hospital insurance, part A, payroll tax in the future. So there will be just so much money coming out of Medicare and not enough money coming in. Okay, trap number 2, penalties. And we're getting a lot of calls into our office about how to make decisions about Medicare. Now, some of you are already in, and you may or may not know some of the dangers having to do with whatever your choice was, because a lot of the agents may not even tell you, which is one of the reasons in this handbook we are going to have the traps, so that you will understand the cautionary things you need to think about before you make a decision, because those first 6 months of you making a decision, whatever you have decided in those first 6 months is probably the decision you'll be stuck with for the rest of your life. You may go from one Medicare Advantage plan to another Medicare Advantage plan, but you may never be able to go back to a regular, original Medicare, because no supplemental policy might say yes to you. Okay, so the trap number 2 is the penalties. Part A, if you it's a much smaller penalty, and it's just like for 2.5 years longer than you refuse to come in, you have to pay extra. But Medicare Part B, it's every 12 months that you have refused to come into B, you will be penalized for the rest of your life. And Medicare Part D, every month you refuse to get in, you will be penalized an increasing penalty for the rest of your life by the time that you get in. So there's these really important penalties about a government program that you may not even want to be part of, but you're forced to do it. Because at some point when you're 80 or whatever, you might decide, if you hadn't been forced into Medicare, that now you want Medicare. Well, the price is going to be astronomical because of how the penalties pile up. So you're sort of forced in. Medicare Trap 3, Medigap policy, the supplements. Like I say, choose wisely the first time. If you don't understand some of these rules, it's really important to know them because you may have to live with it forever. So the price, and so let me see, how should I say this the best? After you'll have a Medicare Part B date, and within the first 6 months, you can choose any Medicare supplement policy, anyone that you wish. There's no medical underwriting. They won't look to see how sick you are. They won't talk to your doctor. You can pick anyone that you want. And then you can make a change within those 6 months if you decide you made the wrong decision. But after that, after those first 6 months, if you want to change because you decided it was the wrong decision, then any one of those policies can medically underwrite you. And just to be clear, I think I should be clear about this. Medicare Part A, hospitalization, let me just say what these are. Medicare Part B, things like doctor's offices, physical therapy, all that sort of thing. Medicare Part D, drugs. And then Medicare Part C is Medicare Advantage. But rather than picking Medicare Advantage, you can pick the supplemental policy. And the supplemental policy will pay for co-pays, deductibles, and co-insurance, which for Medicare is usually 20%. So, and you don't have to have any of them except Medicare Part B if you want to get your Social Security benefits. So, just know what those three parts are. So the Medigap policy, you make a decision, and then what if the price gets too high over time for you? Will you get out of Medicare, Medigap, or will you continue to just pay more and more and more? What if your policy decides it's going away? Then you have the opportunity to pick another policy because you have guaranteed issue then, but you can't pick N. And for those of you who haven't looked at this, this might not make any sense to you, but there's one policy, you have only those 6 months to choose, but they won't tell you that. So there's the other concern that they don't tell you about is that a closed pool, your Medigap policy decides, nope, we're not going to do Medigap anymore. But we're going to keep all the people that we currently have. We're just not going to add anyone new. Well, in order to do that, they have to raise your price and raise your price and raise your price and raise your price. And you may not, and you don't have a choice of guarantee issue because they've kept you. That's another trap. So your price could become completely unaffordable, and yet you can't get out without being medically underwritten, and then you might not be able to even get a policy. Okay, Medicare Trap 4, Medicare Advantage. So this is a really important one. Medicare Advantage, do you have any advertisements anywhere around here that say 0 premium? Okay, the thing to understand about Medicare Advantage as opposed to original Medicare is if you decide to have Medicare Advantage, that health plan gets all the money that the federal government has for you from Part A and almost all the money from Part B. And it gets to take it in, and then it gets to decide whether or not you can have care or not. If you are in original Medicare, you get to choose any hospital, any doctor. There's no prior authorization. None. Except if there's a national coverage decision and they say, well, we're just not going to cover that medication for the entire population of the United States. And if you go to an agent, they're going to try to probably put you into Medicare Advantage because they get so much money to do so. $625 per person, and that's a minimum. Some of them with added bonuses, et cetera, can get up to $1,300 per person that they can get into Medicare Advantage. Medicare Advantage is getting somewhere between, or upwards of 15% more per person than original Medicare pays per person. So they got all sorts of money to give you free bennies, freebies at the beginning, free glasses once a year, silver sneakers, a fitness program, all of these things. But when you need care, one agent says there's about 70 to 75% of the procedures that you might want that you will have to get prior authorization for. And in original Medicare, the doctor orders it, you get it. But they don't tell, the agents don't tell you that because they have their own reasons, right, to get you into Medicare Advantage. And so Medicare Advantage has the authority to ration care, and I call it Medicare Disadvantage. So here's the slide here which talks about all the money that a Medicare Advantage plan gets that's higher than original Medicare. Excuse me. Yeah, thank you. Because the government wants you in Medicare Advantage. So they have made original Medicare more expensive. And they've given all this money to Medicare Advantage, who can then give the commissions to the agents And they can give all those free benefits that you don't get through original Medicare. But the most important thing you have to think about is, what is Medicare for? When you get sick, you get the care you need. That's what Medicare is for. And you have to make the best decision right from the get-go, because once you're in Medicare Advantage, and then you get sick, and then you go, oh my goodness, I can't get anything. Medicare Advantage doesn't even let me go to a cancer center. It's giving me this hospital where they don't even have that much experience with this cancer, but I have no other choice. I'm going to switch to original Medicare. But then they can medically underwrite you those supplemental plans, and they can say, yeah, no, we're not going to pay for your deductible, your copay, or your co-insurance, and now can you afford to get out of Medicare Advantage? That's the question. So you see 95 to 115% of local fee-for-service Medicare costs, that's plus bonus amounts. That's what the health plans are paid by the federal government. So deny, 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 this is words out of an article, and this is a quote out of an article from this healthcare system. They don't want to reimburse for anything, deny, deny, deny. They're taking over Medicare, and they are taking advantage of elderly patients. Next, are you prepared to do a Medicare appeal for the fact that you have been denied? So these are some statistics from the federal government. The Office of Inspector General has done reports, about three reports between 2015 and 2023. 75% of the appeals were overturned, but only 1% of people ever appeal because they're sick, they're dying, they don't understand the process. OIG says it's a huge burden for them to even do it. And then in this 22 report said 13% of the denials were actually covered by Medicare, but the health plan refused to cover them, refused to pay. All right, and here's the appeals process. If you want to appeal your decision for a denial by Medicare Advantage. So that's the other thing you have to think about when you're making a Medicare decision. Now, some of you, if you already have Medicare, there are times where you can change. But the real question is whether or not you could actually go back to original Medicare, because nobody ever told you what the possible traps might be. All right, Medicare trap number 5. This is just a simple realization that now you're essentially owned. They can get every piece of your data because they're paying for you. You have no right to privacy. Your medical records are open. Only approved care is allowed. The doctor's decisions are tracked, and you have no right to the care that you need because this is the government. Now, is escape possible? Well, these are not really great options. One of the reasons why we tried to get the executive order to give you the right to opt out, because we knew, I mean, imagine there's going to be 80 million people in Medicare in 2033, in 9 years. What kind of a huge market would that be for real insurance companies to start having access to, right? If people are actually able to opt out, and they could get real insurance, which is affordable. What you have today as a health plan is not real insurance, it's prepaid health care. It's not affordable. It's like having a catastrophic policy at a prepaid health care price. It's like they're covered everything, and if a policy that would cover everything would cost a lot of money. But they have a policy with what? A $10,000 deductible, $12,000 deductible, you're gonna pay $20,000 a year if you're in regular insurance. That's not insurance, that's a health plan. So a market for 80 million people that's real insurance, that only pays for insurable events, catastrophic coverage, would be a much better idea. Then you won't have your life rationed away as the dollars disappear. So these are, just some of the ideas. Healthcare sharing. There are some healthcare sharing organizations that still allow you to stay in. You can refuse your Social Security benefits and stay out. If you're in VA, TRICARE, or the federal employee health benefits, a lot of times you don't care and you can leave Medicare behind. And then the Retirement Freedom Act, which is what we are trying to get through Congress, but also to do that by executive order. So that's the end of the Medicare. So if you have questions about that, just keep them in mind, because I'm going to just go to COVID update, so you can have some idea of some things that you may not know. So there's been a lot of talk about what happened with the lab leak, and so it's been very interesting, the people who are researching it and looking into things that happened before we even knew about COVID. And in particular, the 2016, Dr. Barrick from North Carolina made this very interesting request to the federal government, asking to go look for bats in the mines of China, not the mines, the Chinese, in the mines of China, and look for them to have what's called a furin cleavage site. And a furin cleavage site makes it more infectious. Well, as one person said, in 1,000 years, they've never run into a bat or with the coronavirus or any coronavirus with a furin cleavage site. So there is some suspicion that Dr. Barrick and company had already started this process and was trying to get DARPA to fund it. And that because the coronavirus that has accosted us all has a furin cleavage site, which is only there by the fact that it was engineered and manufactured, and that's actually what the scientists said to Fauci in 2020, is that they thought it looked engineered. It's part of the gain of function research. This is just to give you an idea of the real money of the award the federal government has given for this kind of research. Here's here's where they put the furin cleavage site. It is in I think this is in Barracks. And these are the places where they cut out of the coronavirus to add things. So when they saw this, they're like, well, this is all manufactured. All right, convincing evidence. The COVID-2 is the only virus in the entire genus of SARS-related coronaviruses that contains a fully functional cleavage site. And this was said by Ebright. And then he's commenting on the proposal from 2018 by Barrick, proposing exactly to engineer that very thing. Just giving more reason to think that what has transpired here is a combination of the United States funding and the Wuhan lab to do this, to create something more virulent through these bats. This is an interesting fact that I thought you have probably never heard before about when you get a shot. So I'm just giving you different kind of updates here. So we're moving now to the COVID shot. Every time you get a booster, right, 13 to 40 trillion mRNA molecules are injected in a few seconds. And then each of these mRNAs can produce 10 to 100 spike proteins. And so they go to your cells, and then you and your body, you have 30 to 40 trillion cells that could possibly be part of this generation of the spike protein. So it's a phenomenal amount of spike protein that can be generated in your body from the shot. Just some interesting facts about the COVID shot. We found out now that the FDA never approved them, that it was just the Secretary of Health and Human Services, all by his lonesome, that did it. I don't know if you've heard about the study of the 17 million deaths. It was in the southern hemisphere, and that's an estimation of, given the data that they found. 2 women have now lost limbs. One lost 2, one lost all 4 of them. It's attributed to the vax. The excess deaths, 40% of the working age in 2021, and in 2022, 23% excess deaths in workers. Here's the millennials and the excess deaths in millennials. 84% increase from back over here. And so this is like the early vax in February of 2021. And this is December of 2021 with the mandates. And now, it's starting to come down, and of course, all sorts of people are choosing not to get any of the boosters, which is good. This is, I can't think of Edward Dowd, he was a former BlackRock manager, does a lot with finance, but decided to look at all of the data. And so he just talked about here the lost working times. And what's so interesting about this is, I have to make sure on my own thing that I can see what this is. Nope. These are the years. The darkest one is 2020. That's right. So 2020, 2021, and 2022. And as he said, isn't this interesting? Because it's increasing. It's not going away just because we're past the COVID time. And here is the lost work time rate. And as he again said, it's increasing. It's not decreasing. All right, next. And so he said maybe the pandemic is in 2022, not 2020, statistically speaking. And then he talked about the disability numbers. The adverse events are 4.5 times the CDC estimate of 1,000 a day. They're more like 4,500 a day that they were getting as a shot was being given. And then this is a brand new organization, Insurance Collaboration to Save Lives, because they are seeing it in all the deaths that they're seeing. That organization started by Josh Sterling, who says things are on fire, and the number of U.S. deaths by increased the number of U.S. deaths by 34.8% in 2021, resulting in basically nearly $900,000 excess deaths that year in 2021. This is his quote. Things are on fire. And then Edward Dowd says Q4 2023 will be worse, but he doesn't have the data yet. And he said that somebody on the inside told him it's just getting worse. All right, just a few more things in case you haven't heard them. The CDC was forced to release their information on 7.8 million injuries. Pilots continue to be incapacitated. When I made this, the last one happened in Brazil. The Netherlands, the Queen of the Netherlands is still saying we have to have vax passports around the world. The tennis player, Novak Djokovic, he got heckled. Did any of you see this?
Yes. Oh, yeah.
Yeah,
Awesome.
and then he aced it. I loved it. Okay. Representative Andy Harris wants to pay the injured. This is a statistic that I have these question marks because I heard it. I can't find it. Can't find the source. I can't remember where I got it. But I remember them saying that the vax hearts work 47% harder for the first 6 months after the shot. And a lot of countries are prohibiting the vax for people under 50 years old, but not the United States. And the turbo cancers are stage 4. They're coming out as stage 4. Any of you know somebody who got cancer that just boom, and it was stage 4 or stage 3?
Yeah.
1, 2, 3, yeah. Yeah, and so it's just, it made the body really vulnerable. Here's the new cancer cases, and here's 2020, right? 2021 with the vax increase, and then how the new cancer cases have just skyrocketed. All of this is to say, really consider twice before you go and get the shot, if any of you are thinking about it. Just a few more things about the COVID update. Interestingly enough, long COVID has hit a lot of people. They've spent $1.5 billion, the government, but not on treatment. So interesting. There's a rise of lung cancer in the non-smokers. There's 200,000 injuries in the young, 20% of 1 million. It's a huge number. The CDC actually had prepared an alert about myocarditis. 5 iterations of it, I think. And then they just never released it. And that was very early in 2021. The New York Times is actually coming around to our sort of thinking about ideological transience that's keeping people thinking that they have to have the vax. So the New York Times, that was an interesting thing to hear from them. And then there's this study, 429 moms died, 300% increase.
So, Twila, those statistics are people who had the vaccine, is that correct? Or is that just as a result of COVID?
Which?
The statistics that you, yes, these right here, those are vaccine
Yeah.
injuries? Okay.
Yeah.
All right.
Okay, and then the next slide, those are the maternal deaths, the orange. Next slide, renal failure. You can see how it went up, 2020, 21, 2022. Looking at Massachusetts. Next, the rise in the vaccine deaths. You've probably seen this one before. I think I probably showed this when I was here. And then this is the group. It's got 36,000 people who have been injured by the vaccines, and they're all trying to figure out a solution. And they're doing their own research because, of course, nobody wants to even talk about vaccine injuries. So they're having to do their own research to figure it out. And then this is from the bivalent virus. So this whole idea of you get a vaccine, a higher risk. Risk of COVID-19 increased with the number of vaccine doses previously received. Next. You get fewer antibodies as a result of the more shots that you get. Next. And then this is my last topic. But I'm going to say something about the shot first. How many of you have listened to Brett Weinstein? Okay, Brett came out with a really interesting statement. He was interviewed by Tucker, maybe December. He had been to the Darien Gap, which is where a lot of the immigrants or the invasion is coming from over Panama. And Tucker asked him some question, and then he reverted to COVID. He wondered what part of COVID this had, if COVID had something to do with this, because he found a camp of young Chinese men, 120 strong about, and they were not interested in talking to him, and they were very unfriendly, and their camp was closed. He couldn't get into it. The other camps had people from all over the world, they could walk around freely. So Tucker asked this kind of question, and then he talked about wondering if all of these, what did he call them? I'm going to forget, sleepwalkers, these Chinese sleepwalkers. He wonders how many of these Chinese sleepwalkers have to get into the United States before essentially another shoe will drop. The next phase is going to happen, right? And so this is the result of Tucker's question. And then Tucker says, what do you mean? And he said, well, the interesting thing is with people who have gotten more than 3 shots is that their body creates IgG4. And IgG4 is meant to essentially shut down your immune system. And so that if you have some major reaction to something, it won't kill you. Your own immune system won't kill you. But you don't want IgG4 against like a pathogen like this. You want to kill the thing, right? And he just said he's just very, very concerned about the fact that perhaps these people will not be able to fight the next pathogen. And then at the end of it, he says, I hope I'm wrong. I hope it's a mirage. But I know the study he's talking about that just talked about the IgG4. And I don't know either. But I think it's something important to understand. He said what he believes is that the people who have had more than 3 shots have had a firmware update. Do you understand the difference between firmware and software? So software you regularly update on your computer, right? But firmware is like changing the operating system. And he's hoping that he's wrong, but he's an award-winning biologist. He's been he has the Dark Horse website, which is all about biology. And I would just encourage you, not only because the Darien Gap was fascinating, it's kind of scary if you're an American who doesn't want an invasion, but it's at the very, very, very end, and you could just like go to the last 8 minutes and start listening, and you'll hear it for yourself, what his concern is. All right, that's this whole idea too about not having antibodies, right? And so the last thing is we have to win the war against ivermectin, and I think I won't show you all these slides, just because I want time for you to have questions. I'm doing fine?
About 40 minutes till we stop the meeting.
Okay, all right, okay. So I just want to say that, ivermectin, I'm sorry?
What do you mean the war against ivermectin?
Yeah, so I'm going to explain it now.
Oh, okay, I'm sorry.
Yeah, okay. All right, so the difficult thing from a person in my position is that everybody wants to leave COVID behind and get on with life, right?
Yeah.
But the fact is that they haven't left it behind. And they use it for their own purposes. And ivermectin was the government saying that a life-saving drug was not available to anybody, that hospitals couldn't provide it, that pharmacists couldn't dispense it, that FBI could go to the borders of this country and stop it from coming in. So they were willing to kill Americans for whatever their agenda was. And now, of course, they just want to leave it behind. But thankfully, there are 3 doctors, Mary Talley Bowden, Paul Merrick, and Dr. Apter, and the lawsuit is called Apter versus HHS, that have gone after the government to say you were practicing medicine. Interestingly enough, this past week, there was a tiny little blurb in Politico that said, in a sealed order, the judges have denied in part and accepted in part. So part of the lawsuit is going to go forward and part of it has been denied, and we have no idea because it's sealed. So nobody's talking, we don't know what it means. But the fact of the matter is the government cannot be allowed to ever do that again. This lawsuit must be won. If I hope if it's a bad deal that has happened there that none of us can see, that the whole thing is appealed all the way to the Supreme Court. And then if it manages in the Supreme Court, the legislatures, they rule the wrong way. The state legislators have to stop this from ever happening again. Because if we don't win this battle against what the government did for ivermectin, we allow them to come back another time and say whatever the next great thing is that could save us from a pathogen, that they can say, I'm sorry, nope, no way, no how, we're going to take away your license, we're going to stop, you paid for that medication, but we're going to stop it at the border. You're a pharmacy, we're going to take away your license if you dispense it. Thank God Tennessee has a law that says you can just go to a pharmacy that is willing to do it, and you can just get ivermectin without a doctor's order. And so that's one state that stood up and said, yeah, not in our state, right? But every state should do that. Because if we lose the battle for the right to have a life-saving drug, the government has phenomenal power in this country to just keep you from living when they have decided that they have a different agenda. I can't remember. See, you're my first presentation of this entire trip. And so I'm like, let me see, what's coming up next? And I just want to show you this one because I don't know if you know this one. Cameroon. Case study. So you all just need to keep this into your brain for anybody who says horse paste, right? Yeah. All right, it's not horse paste. It might be paste for horses, but it's also pills for people. And here's a suicide attempt by a 19-year-old woman. She took 400 pills in a 500-pill bottle. She was sent to the hospital for just comfort care and recovery. So she got fluid, she had diarrhea, she was vomiting, she had some neurological things. Well, they all went away, and she's now in the university studying. She lived, right? This is a very dangerous drug, people. You're gonna die. No, you aren't. It's such a safe drug. And today they are using it for all sorts of other things. And actually the NIH was using it for cancer, looking at it for cancer. And there's a great story. I was just up at Molly James Clinic in Ellisville. Yeah. Anyway, the guy in this story, which was reported on a Substack, has cancer, and he started taking ivermectin without his doctor's knowledge. And his doctor and the nurses and everyone were like, wow, why are you not losing your hair? Why are you still not, why are you keeping your weight? Why are you this? Why are you that? Well, you didn't tell him, right? Anyway, and then the next time that they actually did a radiograph or whatever of his tumor, it was like something like 80 or 85% of it, or maybe even 90% was just fibrous tissue, right? So, and this is ivermectin. Just a few more studies in case you forgot. A reminder that Deborah Burke knew that the COVID vaccines would not protect against infection. She certainly wasn't admitting what could. This is Dr. Mary Talley Bowden. She's one of the plaintiffs, and this is Dr. Pierre Corey talking about the coordinated campaign amongst agencies to limit the use of ivermectin. And then my last statement about this, it's a battle over who will control the practice of medicine in America we can't afford to lose. So the next slides are just a few slides about our organization. You can just keep flipping. Here's our quick reference guide. The Wedge of Health Freedom, where you can find a cash practice like Molly James' practice is on there. Here's our principles. Go to jointhewedge.com to find one of those doctors or nurse practitioners or pharmacies. Oh,
Sorry.
next. We're planning to build a parallel system where this is the model that we should have. That's the model of today. Payers on the top, patient and doctor on the bottom. Everybody waits to see what the payer will do. In the future, this is all cash-based. The insurer pays the patient pays the doctor, patient pays the hospital. Every price is transparent. Everything is competitive because they all know what their prices are, just like in LASIK surgery, right? It's very competitive to get you to come to their services. And this is the only way that it becomes affordable and patient-centered, because you hold the dollars, you are the customer. That was the wedge there, and this is Big Brother in the Exam Room, my book. And then if you want to support our work, which would be great, and if you give tonight, that's just be wonderful to help along the way. And then the last thing is just our social media. So I know that was a lot, and it was 3 different topics, but I hope it proved interesting, and I'm happy to answer questions.
Well,
Yes.
a couple questions. One is, why were the physicians so uninformed about the use of ivermectin?
Okay, so it's interesting. Molly James' own story is interesting because she was an ICU doctor in Missouri, and she never heard about ivermectin because nobody was telling her about ivermectin, and she's just trying to save COVID patients, and like every hour of every day is probably just trying to deal with the whole COVID, all the patients coming to her, right? And so, but somehow she got wind of ivermectin as a possibility, and she looked into it and she thought, oh, I think I'm going to treat some of my COVID patients and we'll just see how it works. Well, it worked really great. So she started ordering it, and then the hospital figured out that she was ordering it, and then the hospital told her cease and desist from ordering it, and then they ousted her because she refused. And then she started her own clinics, and she's got I think she's about to do her 6th one around the country. And Dr. Paul Merrick, he got wind of it somehow too, because he'd been looking at different reports, and Peter McCullough was out in March of 2020 saying hydroxychloroquine. And Fauci himself knew that chloroquine was useful against SARS-CoV. So he knew it in 2005 because his agency funded it. And so they knew that this was a possibility, right? But if you're employed by a system, and 70 to 75% of doctors are today employees, and their children's education is on the line, their entire profession is on the line, their license is on the line, right? They may not even want to look.
Well, there's the whole thing about people being censored. You know, Americans Frontline Doctors tried to come out early on, and so that was a big deal too.
Yeah.
So what's the importance of hydroxychloroquine in use with ivermectin? Do you need both, or is ivermectin just fine?
So the good answer to that is for me to tell you to go to flccc.net and look at the protocol. So for a while it was just ivermectin, or you could have just hydroxychloroquine. But now I know that in the later forms of COVID-19, they are recommending both. And you can find the dosages and everything else in their protocol.
Can you give that website again?
flccc.net. It's a frontline COVID-19 critical care alliance. Sir.
Yep, I wanted to say it's a very easy site to follow, and you can download the PDF, and it's all written out for you.
Yep.
I wanted to say I was in the emergency room at the time, and when COVID started, and I saw from the ER doctors, it was day to day, the protocols changed, and they would say, how are we supposed to treat this now? And I saw many patients die because of the way they were treated, and the next day, the protocol changed. And I wanted to say on PubMed, there's some really good information, if it's still there, on ivermectin and cancer.
Yeah, and shingles. So there's somebody, I can't remember who, it was Tess Laurie in England, got an email from a retired physician who was with somebody who was complaining about her shoulder or whatever, and he looked and he goes, oh, that's shingles. And they didn't have any way to get to a doctor really quickly to get the kind of medication that would be needed, but he remembered that he'd heard some little thing about it being useful for shingles, perhaps. So he just gave her ivermectin, and by the next day, it had resolved about 50%. And then by the next day after that, it was basically just a red spot and no longer blisters.
Wow.
So it's a miracle drug. It's been called a miracle drug for a long time. Yes, ma'am. Yeah.
I'm gonna switch off of COVID and talk
Yep.
about Medicare.
Yeah.
I'm a therapist in the healthcare profession, and I just wanna, and I hope you can expand on this. There are things that we have to ask as therapists, providers, that you do not have to answer. And I wanted to get the word out because I don't want you to answer. Now, there are some things that we need and some things that you don't, but the latest is a social drivers of health screening. Have you heard of that?
Yes.
So here's a couple questions. Are you homeless or worried about what might be in your future? Do you have trouble finding or paying for a ride? Do you need daycare or better daycare for your kids? Do you need help finding a better job? Do you feel unsafe, and are you concerned about someone in your house using drugs or alcohol? If you get that questionnaire, just say refused, and I'm gonna go, woohoo, they refused. You do not have to answer this. I feel as a therapist that I'm becoming a data collector, and I am not comfortable with that. Like I said, there are some questions, I have to do a photo. If you don't fill out that photo, then I can't bill your Medicare. So there's some things that I have to ask you and you need to answer, but if you would ask me, do I need to fill this out, I would say, H-E-double hockey sticks, no.
So this is called the Social Determinants of Health Initiative. It's popping up in legislation at the state level and at the federal level. And they're being paid to get this information because they're saying that everything in your life will determine how healthy you are. And so I actually have some flyers of the social determinants of health that we did and we gave to members of Congress to tell them to go on a search and destroy mission to find every time social determinants of health is in a piece of legislation and get rid of it. Because it's essentially very socialist or Marxist to gather everything in your life, from your education to your income to your family relationships to your behavior to do you have parks in your neighborhood? What kind of car do you have? Do you have a car? Can you have access to bus? It's like this huge expose they are trying to figure out on your entire life. But this is popping up in state and federal legislation. There's money for it. And so you do, I totally agree. You just have to say, you just refuse. The only questions you should answer are the ones you think actually have to do with whatever reason you're there. And you know, I like to tell people that I'm sorry that you have to put on armor on your way into the exam room and into the hospital, but you really do, because they have a different agenda. Too many of them have a different agenda, and you have to stand up for yourself.
Twila.
I know there's this man back here who I actually called on first. But who's got the microphone? Oh, okay.
I'll go back there next.
Yeah, right here.
Do you think there's mRNA in anything else, like a flu shot or anything?
So I know that Moderna, so look at the word Moderna, right? You'll see at let's see, MODERNA, right? So the whole purpose of Moderna was to create things that are mRNA. And so their plan is to do as much as possible with mRNA, including flu vaccines and all sorts of other things that they are thinking of using mRNA. But you know, it is an untested technology. It has all sorts of problems that we have seen in the shots, and nobody should just accept mRNA as something that they should just take into their body without knowing.
Who is in line next?
This man right here.
Going back to funding for Social Security and Medicare,
Yeah.
have you factored in, as far as untested technology, the fact that artificial intelligence doesn't pay income tax when they replace you in a job? And have you factored in illegal immigration who work for cash and don't pay money into the system, how that's going to affect the budget?
Oh, well, no matter what happens with either of those, the budget is in dire straits. So it's already at 89% that the bills will be paid, and that's only an estimate, right? I mean, you know, it did get 3 more years of life, and I do think it's just because a lot of elderly people died from COVID. But there are all sorts of things that could change the budget in all sorts of ways. But what we know is it's already in trouble. Next.
I would just like to tag team on to some of the things you say. I would like to disclose first and foremost, my name's Sandra Bullinger. I'm a pharmacist. I have a private consulting business, self-employed, and I want to go back to the COVID injections. I do not call them a vaccine because it is not. I brought some exhibits with me that I want to share.
Show and tell.
So first of all of you, I'm sure, have seen at some point a package insert, because they're in everything that you purchase. A bottle of Motrin creams, ointments. Okay, and so when you look at the package insert, very little teeny tiny writing. For those of you behind me.
4 languages.
Yeah, and this, it tells you everything. It tells you the contents of what's in it, the dosage, how it should be stored, everything. Anything that was encountered during any research, any adverse effects, everything that you need to know. And this is actually just a package insert out of a box of insulin. So on the back of here, it even shows you how to use it as an insulin pen. So it shows you what you need to do to use that pen. Now, as I was out doing my consulting duties, I was inspecting a med room and a med cart, and I came across a box of COVID injectable. And I thought, just for grins, I'm going to take a look at that injection box, at the package insert in that box. And so I have another disclosure to tell you. You can see remnants of the package insert in my bag. That happened because my daughter was visiting me from out of state, and she has 2 dogs. I do not have dogs, and so I'm not used to a dog getting into my computer bag searching for dog treats. So I guess the dogs thought it was a dog treat. And I think Satan was probably at play as well. But needless to say, I thought, I'm going to get out that package insert and I'm going to see what does it say. So I think even with part of it eaten, you'll still be able to get my message.
You think the dog will have myocarditis?
I thought of that, but so far, no. But we don't know the long-term effects yet. So, my message to you is there is nothing on this package insert. It doesn't tell me the ingredients. It does not tell me how to store it. It does not tell me how to inject it. It tells me absolutely nothing. How long have these injections been on the market? They still don't know enough to tell me the ingredients or how to store it.
They've locked it for 75 years.
Amen.
They have to tell you.
That is right. And so today, whenever I was going, I thought, oh, hopefully they'll forgive me that I'm bringing a half-eaten package insert, but you can still see. Lo and behold, I was looking on the one side, it says COVID-19, it's a 23-24 formulation. It says COVID-19 vaccine intramuscular injection. But then I was getting ready to fold it back up, and it says COVID, the 2023 adjuvanted suspension for intranasal administration. So I don't know if that's what's coming down the pipeline. So is it still being given intranasally? No. It's now only, they've pulled that from the market. They've tried several formulations in the past with the flu vaccine. No success. Now they're going to try it with COVID. And they're trying it with SARS. And let me just tell you, I don't want anyone just to take my word. I want you to do your own research. I just want to present facts so that you can determine it yourself. It was very upsetting to me whenever I discovered this, and it was just before I came, so I haven't really calmed down from it yet. But whenever you are putting something in your nose and you're breathing it in, where's the first place it's going to go?
Right.
Your lungs. What was the number one problem with COVID?
Breathing.
Lungs, right? Respiratory pneumonia. So now this is going straight to your lungs. It's not going through your muscle, through your circulatory system. It's going straight to your lungs. The second thing is that whatever doesn't make it to your lungs can retrograde backwards to your brain. So, as I said, it's very hard for me to even say this, but I feel like I have to pass this on so that you can pass it on whenever we start seeing these intranasal things coming our way, that we are informed. So thank you.
I'm just going to add too that Brett Weinstein mentioned the fact that China never gave any mRNA shots to their own people and gave nothing that caused their own people to create the spike vaccine, the spike in their own bodies.
Twila,
Yes.
this is just an aside. Every time in that Super Bowl, we saw an ad from Pfizer. I wanted to shoot the TV.
That is an aside.
It's unbelievable.
I know Linda,
I was like,
I saw Linda's hand up. Did you still have something, Linda?
No, I forgot.
it's
Okay.
wild at our house.
All right.
I have one little question.
I know Donna said, to avoid the questions, the social questions and that. Does the doctor's reimbursement get affected by the questions that are not answered?
So here's what I would say about that is quality metrics might determine, I'm not positively sure about that, but the fact of the matter is every doctor is being graded on quality, and it's whatever you think quality is, and for them oftentimes it's compliance, which is one of the reasons why they are often pushing for the shots, because having, 90 or 95% of the entire population vaccinated for the flu or vaccinated for COVID or vaccinated, whatever you want to call it, for the vaccine, they have those metrics and they check the entire practice. And that actually makes peer pressure in the practice, one doctor against another. If one doctor is going to give you more freedom, not push, and another doctor is going to push, and then they're figuring out that this doctor has only 50% of his patients, he's making our clinic score look bad. So I don't know the degree to which that's happening with the social determinants of health.
And they're actually reimbursed, you know, that, reimbursed for vaccine.
Yes. Yeah.
We call it.
Yeah. Yeah.
I can say from our clinic that there are some things that we have to include, and if we don't, we get docked. And we don't get docked this year, we get docked in 3 years. So what we don't do this year, they're gonna drag out to, in the 3 to 5 years, and then we will be docked percentage-wise if we don't participate. So that's why there are some things we have to include, otherwise we will not get reimbursed.
Yeah. So
And
the
then we
pressure's
can't
on.
bill the patient because we didn't tell them we couldn't bill the patient. So then we just eat it, and then guess who gets to pay for it?
Right.
The next
Right.
person that comes in with insurance.
I'm just going to say before Jan speaks up right here. So here's my book, Big Brother in the Exam Room, The Dangerous Truth About Electronic Health Records, 8 awards. A lot of the judges said, wow, just never knew. And so I do have books here. You're the first audience that gets the first shot at them. This is the third printing. It now has an index in it, so you can look up anything that you want and try to make it a really in-depth index. It's $25 for the book, and I'm perfectly happy to sign it, so thank you.
I do want to put a plug in.
Wait a minute.
Okay, I'm sorry.
Pass these, please.
Okay.
I don't want anybody to leave without donating to Twila and all of her efforts, so if, let's go ahead and get this going. Go ahead.
Back during COVID, I left my doctor because she yelled at me all the time because I wouldn't get a vaccine. And so I just said, enough of that, I don't need to be yelled at. So I ended up in Dr. Andrew Satterfield's office. And I told his nurse when she came in, she was going to put the Q-tip up my nose, and I said, don't open that because you're not putting that in my nose. I have a sinus infection and need an antibiotic. It comes every year in January. And the doctor came in and he said, I see you don't want to have a vaccine. And I said, I will not have a vaccine. And he said, I think that's just fine. And he has never once, it's been, I've been to see him 3 times now, and he has never since asked me about a vaccine, ever. So he's seeing new patients, by the way, taking new patients. So if you are looking, you don't have to worry about Dr. Satterfield bugging you about a vaccine.
Very nice, very nice.
Just say Kids Forbes sent me and I'll take care of it.
Any additional questions? Medicare?
Not a question, but how can people pay for your book? Cash, check, or do you take a card?
I can't yet take a card, sorry.
Okay, so cash or check?
Yeah.
Made out to?
CCHF.
Citizens Council for Health Freedom.
Yep.
So I'm a junkie. I've been following Twila for how many years now?
A long time.
It's been a while. It's been a while. So books here for sale, $25, and as the door price. Any other questions?
I have one.
Yes, sure.
I have a friend that takes ivermectin every day.
Oh, yeah.
Is that a good idea?
Oh, that's a really good question about
Yeah.
taking ivermectin every day. So there's a lot of people taking it prophylactically, and it does have a really good, record prophylactically, although I'm not positively sure about the newest strains. So I have 2 things. One is that some doctors say no problem whatsoever, but Dr. Kat Lindsay, she's in Texas, and she said, I don't think it's a good idea because it's not a good idea for your gut. But you can prophylactically take it like the day before you're going to, this is me talking now, like the day before you're going into a group like this, or the day before you get on the plane, or if you're going to some big conference, take it during the conference. But then, when you're kind of in your own realm, it's up to you, of course. We've got these 2 opinions. But there's, I like Kat, and I like a lot of what she says, and And she was on a broadcast and she just said, I disagree. So